Good afternoon. Thank you all for being with us today. We have an amazing panel of experts with us, and as we were just talking before we let people in, this is a topic where I think everyone joining here will learn a great deal this afternoon. And as most of you know, the goal of our Safe Babies, Safe Kids Task Force is really to focus on how do we improve the health and welfare of the almost 500,000 kids and young people in Middlesex County, ranging from before birth to college, and counting our birthing hospitals up to our 21 colleges and universities. So we focus on a variety of issues. There's been a lot of interest in the topic we're talking about today, and I think clearly there have been, over the last few weeks, lots of discussions from many different perspectives on postpartum depression and mental health. And we wanted to really, without talking about the facts that underlie those conversations in that case, but really harness that focus on postpartum depression, a condition that we know and the data clearly shows is so widespread across the state. We know that as many as 1 in 5 women are affected by maternal mental health conditions either during pregnancy or in that year after they give birth. And among those who experience those perinatal mental health conditions, as many as 20%, so again, the 1 in 5, will experience suicidal thoughts or undertake acts of self-harm. And as the World Health Organization noted this past fall, when it launched a guide for the integration of perinatal mental health in maternal and child health services, and I quote, ignoring mental health not only risks women's overall health and well-being, but it also clearly impacts infants' physical and emotional development. And that is a way that it really brings it to us here at the task force. And our task force view has been to bring together representatives from healthcare, from law enforcement, from child welfare, social services, legislators at the state and federal level to look at issues and think about cross-sector, multidisciplinary strategies to keep kids safe, whether it be through education or prevention programs. We are incredibly fortunate, as we always are, to have federal partners here. We have representatives from Senator Markey's office who are always quick to join us in these efforts. I know we are joined by Senator Jalen, by Representative Khan, by former Representatives Jamie Balsito. A number of other legislative staffs are represented here. So we know that what we're talking about and what we're going to learn from today is really going to reach back both into our healthcare providers. I've seen some of our police chiefs and fire chiefs, as well as community providers. And, you know, when we talk about, and this will be a piece that I think is a little bit different than where some of the focus has been, as we talk about the issues of maternal mental health, particularly in the time following the birth of their child, we can't talk about that topic without reckoning with the reality that childcare is simply financially out of reach for many families. And the reality is that many women and people giving birth who are employed outside the home are also dealing with these issues and then trying to make a determination about how here in Massachusetts, a place where the Women's Bureau, which is an agency within the United States Department of Labor, which recently launched a national database of childcare costs, has shown that Massachusetts counties pay the 3rd highest childcare prices in this country. The annual cost of infant center-based childcare in both Middlesex and Norfolk County, a list we do not want to be at the top of, but is more than $26,000, according to that data. And that can make up to nearly 20% of a median family budget. The only places in the United States that are more expensive than Middlesex and Norfolk County are Arlington County, Virginia, and San Francisco, California. They are the only places. So we want to be thinking about how do we do better at getting ourselves in a different place on that list. We also know that, like as with every issue, this issue of maternal mental health and postpartum depression is really affected by the realities of structural racism and barriers that cause a disparity in access to care. Women of color are twice as likely. Twice as likely. We already know it's 1 in 5. Now they are twice as likely to experience maternal mental health conditions. And yet they're half as likely to be able to access treatment. So twice as likely to have the problem, half as likely to be able to access treatment. And the maternal mortality numbers for women of color are overwhelming. I think one of the things, and I know I say this for myself, when I had my children, I really, prior to being in the obstetrician's office, hadn't thought a lot about the loss of health that are, or fatalities that occurred from mothers. I think when you're pregnant, you're always focused on your baby's health, and is the baby going to be okay? But we know that women of color are 3 to 4 times more likely to die from a pregnancy-related complication compared to white women. And this statistic has only been growing over the last couple of decades. Dr. Indita Makuma Unikor, who is a professor of Black maternal health in the Department of Public Health and Community Medicine at Tufts, and an assistant dean for diversity and exclusion, who had hoped to be with us today and was not able to join us and will hopefully be here at a future meeting, tells us that her research focusing on those disparities around maternal mental health for Black women makes the sobering point, and I quote, "We're starting to recognize that even after you control for differing factors like pre-existing health conditions, chronic conditions, we still see that great increase in the number of Black women dying during childbirth or from a pregnancy-related condition." And I want to take a moment right at the beginning to really commend our legislative partners and all on the call who advocated for the creation of the Special Commission on Racial Inequities in Maternal Health. And I mentioned the folks that we have here, and should have included as well, we have staff from Senator Liz Miranda's office. Representative Khan, in partnering with Senator Miranda and others, introduced legislation in 2021 to create the Racial Inequities in Maternal Health Commission. It's a 28-member body, and it's charged with investigating just what I talked about, investigating the issue of the increase in deaths among Black women in maternal health situations at the state level, and trying to develop methods to reduce the racial inequities in maternal health, and then propose policies related to birth inequities and breaking down the barriers. Remember, I said they're half as likely to be able to access care. So part of the charge for the commission is breaking down those barriers to prenatal and postpartum care. And I encourage you all to take a look at the comprehensive report that the commission published in May of 2022. We'll put that in the chat. And a top line of that report, and a really unsettling takeaway, was, and I quote again, "Despite being a country that continuously ranks high in technology and innovation, the United States ranks lowest, so bottom of the list, in maternal health outcomes for birthing persons of color." And I'm really grateful that Dr. Mittal, who's here with us, who served as a member of that commission, will have an opportunity in a few minutes to talk about that. As I mentioned, we have an incredible group of experts here with us. So I want to turn it over to them so you'll hear about that, how they came to this work. I have some questions for people. I invite you to either, when we get to that point, put your questions in the chat or use the raise the hand function. And I again want to sort of illustrate why it is so important for a DA's office to be convening on postpartum depression, and why this is so important to me personally. And part it is because I serve as the only female DA in Massachusetts, so I feel a particular responsibility to look at these issues. I really believe that when it comes to these kinds of problems, you have to take a multidisciplinary approach. Problems just are multifaceted, whether it's the opioid epidemic or gun violence. But when you want to move the needle across our 54 cities and towns and look at the almost 2 million people who are living here and raising their families, programs that bring people together from different aspects of the issue really are what have been most successful. And this task force is really a reflection of the strategic vision we have, that we are trying to be the most dedicated, the most innovative, and the most transparent DA's office in the country. And we never should leave to healthcare alone the solution on these kinds of issues. I think there are opportunities for all of us in thinking about, first of all, how can we raise awareness? If there is any good that has come of the recent tragedies here in Massachusetts, it is the increase in awareness. I think one of the, probably many of you have seen, one of the most compelling pieces has been just the number of women who have come forward talking about the fact that they could have been in the shoes of somebody who did something in the throes of either postpartum depression or in the psychosis that can be a part of that. And those are voices we weren't hearing before. And I think it's also important for us to be thinking about, how are we interacting with people that are close either to giving birth or after birth? How are we screening people? Are we asking those questions about, how are you? What can we be doing? Can we let them know about resources that may exist? And then I think for business and government, are we crafting policies and practices that ensure that we aren't contributing to the staggering racial inequities in this area? So I invite you, no matter how you come to this issue, as we talk about this, to sort of be kind of fashion some concrete ideas for your own sector. So I thank you once again for being here. I want to introduce our panelists. And I begin with Dr. Nancy Bryant, who is a professor of, is a perinatal psychiatrist and a physician scientist, focused on really improving systems of care to promote the mental health both of parents and children. Dr. Byatt is a professor with tenure of psychiatry, OBGYN, and population and qualitative health sciences at UMass's Chan Medical School. Dr. Byatt developed the Massachusetts Child Psychiatry Access Program called MCPIP for Moms, which is a statewide program that does three things. It increases access to mental health for thousands of perinatal individuals. It's become a national model for perinatal mental health care, and it's impacted state and national policies and funding. She's also the founding director of the Lifelines for Family Center and Lifelines for Moms program at the Chan School. She's gotten continuous federal funding for her research for over 10 years. She's written over 90 peer-reviewed publications and book chapters, and done over 250 presentations, and won national awards for those. So we're very, very grateful to have her here today. We are appreciative, as well, as I mentioned, of Dr. Lena Mattel, the chief of the Division of Women's Mental Health in the Department of Psychiatry at Brigham and Women's. She is the associate vice chair for diversity, equity, and inclusion at Brigham and Women's. And she also serves as the program director for the Women's Mental Health Fellowship at the Brigham, and co-chairing the Equity Committee, as I mentioned. She is an advocate for the needs of perinatal individuals and marginalized population, whether it be at a local, state, or national level. She, as well, has numerous publications, speaks nationally on the treatment of mental health and substance use conditions, something else we've tackled a lot at the task force, through pregnancy and the postpartum period, as well as racial equity in maternal health care. Dr. Mattel is board certified in psychiatry, psychosomatic medicine, and addiction medicine. So we're very grateful to have that perspective that you bring to us today. Our third panelist is Jill Ashton, who serves as the Northeast Regional Administrator for the United States Department of Labor Women's Bureau that I mentioned. She is a leader and activist in the women's advancement community. From 2009 to 2021, so a very, very long stretch, she served as the Executive Director of the Massachusetts Commission on the Status of Women. And during the 2015-16 legislative session, Jill led the coalition of organizations that successfully stewarded the passage of the Equal Pay Act, which was a really groundbreaking economic justice legislation that, among other provisions, prevented managers who were hiring from inquiring about salary histories. And we all know the research that shows when you can ask about that, women tend to get paid less. Jill's been committed to developing talent among young women and men, having mentored more than 200 students through the Commission's robust internship program. She currently serves as the previous past president of the National Association of Commissions on Women, with which she has increased the peer-to-peer learning opportunities to encourage the success of the members of those commissions. She's a graduate of the Program for Women in Politics and Public Policy at UMass Boston and serves as a member of that center's advisory board. And as well, although I haven't seen her yet, we have with us Professor Kirsten Kramer, who is a sociology professor at the University of Calgary, has a PhD in socio-legal studies in criminology and a bachelor's degree in sociology. She is the author of a book called Unwilling Mothers, Unwanted Babies, Infanticide in Canada. Her research areas focus on law and society, criminology and social inequity and social justice. Her expertise is on the criminal law of infanticide and its applications in the cases of killings of children, very young children by mothers. Dr. Kramer was quoted in recent articles in the Boston Globe on this topic, and I'm really glad she's here, literally Zooming from Canada, to give us that international perspective as we look at, the justice system is not immune from having to deal with these issues as well. And she'll talk a little bit about the biological and social conditions impacting new mothers and how other countries look at that. And last, but certainly not least, I'm delighted to have with us Jessie Colbert, who is the founder and executive director of the Massachusetts Postpartum Depression Fund, a nonprofit that she founded in 2018 in response to really a lack of adequate investment in mental health for new parents. And her organization plays an important role in what I talk about, that awareness and breaking the silence around postpartum depression, related mental health issues, and improving access for new parents in Massachusetts. Jessie has over 20 years of nonprofit experience. She served as the development director and assistant development director for Mass Budget, which is a state level think tank. She was also the first director of the Ellen Story Special Legislative Commission on Postpartum Depression. She serves as an appointed commissioner to that commission, the Ellen Story Commission, and on the Massachusetts board of the March of Dimes and the Boston Women's Leadership Council. So you can see we bring a wealth of experience and diversity of scholarship around these questions. So I'm going to begin by asking each of you to talk just for a little bit about your work and how you came to these issues and just your reflections in general as these conversations that have been really going on everywhere over the last few weeks. And I'm going to begin, if I could, with you, Dr. Byatt.
Thank you. Thank you for the lovely introductions. It's a pleasure to be here. Thank you for holding this important event today. So I came to this work actually because, so my original thing was personal, because when I grew up, I was acutely aware of the importance of maternal mental health because I saw my mom struggle with her own disrupted bonding or attachment with her own mother. So I was acutely aware of the importance of it. Then, you fast forward, I became a perinatal psychiatrist, no surprise there. And I was doing my fellowship at Brigham and Women's Hospital, and I was seeing individuals. I did a fellowship in consultation liaison psychiatry, which is focused on really providing psychiatric consultation to inpatient, to generally to settings where people are seen for medical reasons. And as I did that, I had a clinic where I was seeing pregnant and postpartum individuals in an obstetric clinic as a psychiatrist, and I was providing ongoing care. And what I was seeing consistently was that people would come in to see me. I had a very long wait, and a lot of times the treatment people needed wasn't particularly complicated, and the OBGYNs were really struggling, and they were seeing these women all the time. However, they didn't know what to do. So we had this situation where I had a really long wait for people to see me. That didn't feel right to me. And the OBGYNs were wanting to help, but really didn't have the access or resources to know how and what to do in order to respond to people presenting with mental health concerns. And I remember this one particular patient presented and described her experience with her baby. And she came in and she described that she when the baby was born, she felt like she was a black hole, and she really didn't feel like she was falling in love with the baby. And then she described that it took her a year and a half to come out of this, and the whole time she had absolutely no idea that she had depression. So there was a few things that struck me about this. One was that she had absolutely no idea that she had this, right? Two was that she was seen in those settings by obstetric providers, pediatricians. She was seen by so many healthcare providers. Nobody ever asked her about depression. Nobody ever talked to her about mental health. And there were so many missed opportunities. So she struggled for a year and a half, and she didn't even know that she was experiencing this. And when we think about, medical illness as a parallel, we would never tolerate someone being seen throughout their whole time and never being screened for diabetes. And we don't expect people to tell us they have diabetes, right? We don't expect people to say, well, they didn't tell me they had diabetes, so why would we know? So I really was struck by the gap in care where women are being seen by, pediatricians, obstetric providers, in all these settings. And no one was asking about this. It was a total missed opportunity to talk about these illnesses and to provide treatment, help link people with ongoing care when that's indicated. And then, and the OBs didn't know what to do. So because of all that, and as has been mentioned, these barriers are magnified, particularly for populations that are marginalized, by race by racism or other forms of oppression. And so what my work has really focused on is changing healthcare systems so that mental health is on par with physical health. And so, for example, when someone's seen for their obstetric visit, they're screened for depression, it's discussed, individuals are told that, we're going to be screening you and discussing mental health because it's twice as common as diabetes in pregnancy, and this is going to be part of your care. So I'm happy to talk in more detail about what we do. You mentioned MCPAP for Moms. Lena is also a leader in MCPAP for Moms, so I'm sure we'll both be talking about that. That is a statewide program we developed that aims to build the capacity of the medical community to address mental health and substance use disorders, because the lack of access is really unacceptable. And so that's a high-level summary, and I'm happy to provide more details later. Thank you.
Thank you. Thank you, Doctor. And turning to Dr. Mattel.
Thank you again for the invitation. And, I will say that I also am a perinatal psychiatrist. I have a relatively similar path, kind of through training and learning as Nancy does. I will say that I've also come to women's health and women's mental health through a history of advocacy, even prior to going into medical school. I went to medical school after having been a reproductive rights advocate and having worked at Planned Parenthood as an undergraduate and thinking I was going to go into medical school to become an OBGYN. And then really through training, coming to learn that I really loved actually the talking aspect of mental health care and getting to know people and getting to help colleagues and patients understand what's really hard to understand about people. Mental health often eludes many of our very, very brilliant colleagues in healthcare. And so there was a way in which psychiatry really fit that for me. And I did the same fellowship that Nancy did. We actually met when she was a fellow and I was a resident at the Brigham. And during that fellowship where it's a consultation psychiatry fellowship, a lot of what we do is sort of serve as ambassadors of behavioral health care to the other parts of the healthcare system. And what became really clear to me was that there are things like pregnancy status or mental health diagnoses or substance use disorder diagnoses that become what I call the hot potato of medicine, where people just take a giant step back as things get more and more complex, or they enter into areas where they're less comfortable. And that strikes me as a real disservice to people who need actually people to lean in and need systems to lean in. And so it has been, my privilege to be on faculty at the Brigham and Women's Hospital since I trained there, to grow our women's mental health program, where we're really able to say, this is something that we understand, and we have very, very strong collaborations with obstetrics and gynecology and newborn medicine in our hospital. We really sit within the sort of intersections of these three large fields. I have the privilege of being a consultant for MCPAP for Moms and the medical director for equity, substance use, and community partnerships there. And through that work, I've had the distinct privilege of being able to sit on the Ellen Story Commission for Postpartum Depression and the Racial Inequities in Maternal Health Commission. And I have been a member of the Maternal Mortality Review Committee in our state through the Department of Mental Health, where I really get to kind of interface with so many colleagues who are kind of coming at these challenges of maternal health and maternal mental health from all of these different angles of expertise. And we really get to put our heads together and think collaboratively. So I'll stop there. That's sort of how I come to this work. I'm happy to answer more questions, but I want to leave time for the other panelists.
Thank you so much. And Jill, we'll turn to you to talk about, the majority of women are working before they have their baby. They're going to be working after they have their baby. Like, tell us what you've been looking at and what that impact is.
Sure. Thank you so much for having me here. And thank you so much to DA Ryan's team for supporting me in this engagement. As a reminder, my name is Jill Ashton, and I serve as the Regional Administrator for the U.S. Department of Labor Women's Bureau. And for those of you who, actually, one quick second, I just wanted to acknowledge, I see so many familiar faces and names in the number of participants today. And I just want to recognize all those folks who have been either partners or collaborators or mentors to me, and appreciate the opportunity to be in conversation with you all today. So for those of you who are not familiar with me or my work at the Women's Bureau, we at the Women's Bureau fight for the rights of working women, and we have done so for 100 years. Our mission has been to push for better jobs, wages, and benefits for women in the workforce across the country. We do this by deploying a complement of strategies, including research, policy analysis, grant making, and stakeholder engagement. We this year have 5 key priorities, and I'll try to zip through them very quickly. I want to just kind of tease them to folks in case there's another area of our work that you might be interested in. They include doula care work, FMLA/paid leave work, access to affordable quality childcare, equity and infrastructure, and then gender-based violence and harassment. For the purposes of this conversation today, I'll focus on the first 3. But again, if anyone has questions about the rest of our portfolio, please do not hesitate to reach out. And then the other thing that I'll say is I will drop links to a number of resources that we'll talk about today into the chat so folks have access. So first off, the doula work that we're engaged with. This is an extension of the White House's blueprint for addressing the maternal health crisis. A number of experts will speak about exactly what we're seeing in terms of the numbers, so I'll skip over my statistics in this conversation. But I do want to draw your attention to the document. Again, I will share it in the chat. There are 5 key goals to the blueprint, including increased access to and coverage of comprehensive, high-quality maternal health services, including behavioral health services. Number 2, ensuring that those giving birth are heard and decision makers in accountable systems of care. Number 3, advanced data collection, standardization, harmonization, transparency, and research. 4, expand and diversify the perinatal workforce. And then 5, strengthen economic and social supports for people before, during, and after pregnancy. And so the work that the Women's Bureau will be leading is around the doula workforce. We are hosting a series of listening sessions. The first will be held in Rhode Island on the 23rd of February, and the first will be held in Rhode Island on the 27th of February. The second is on the 23rd in Alabama. The work that we're doing in the Northeast will be to be in conversation with doulas who are providing essential services to their community and who have the ability to access reimbursement through insurance. The doulas that we'll be speaking to, or my colleagues will be speaking to in Alabama, do not have that opportunity. So this is where the conversation will begin around the doula workforce experience, but we know that we will uncover other issues in conversation with the doulas, and we're looking to have a greater, deeper, more nuanced understanding of their experience as an important component of addressing the maternal health crisis. I don't know, the work around paid leave. So we just recently celebrated the 30th anniversary of the Federal Family and Medical Leave Act. And when the act was passed, of course, it was groundbreaking in terms of ensuring that folks could take leave and more importantly, have job protection and not lose their benefits. We know that this is just a starting place in terms of the work that needs to be done, because access is not equitable at this time, even when the legislation, again, groundbreaking as it was when it was passed, was limited in terms of who was able to access and who was able to take that leave with the protections. We at the Department of Labor are working in the direction of universal access to paid leave. In Massachusetts, of course, our state led the way in securing paid leave, but again, access is still not equitable. And where are there opportunities for us to understand more deeply the impact of paid leave in terms of working families, and how can we expand access, and again, with an equity lens. And then finally, as mentioned earlier, we are thrilled to have released just recently the National Database of Childcare Prices. This is a comprehensive interactive product that gives a micro look into the unbearable costs of childcare in this country. And as again was spoken about earlier, we in Massachusetts have the highest rates of childcare. This is significant for working families. So in 2018, and this is the year that we were able to access sort of the most comprehensive recent data, the median yearly childcare prices for one child ranged from $4,810 to $15,417. Adjusted for inflation, this equals between $5,307 and $17,171. And this is in this is in 2022 dollars. But then prices vary depending on care provider, the setting, age group, and county size. And so again, when we're looking at the cost of care in Massachusetts, it increases significantly, up to almost 20%. And when we're looking at the cost of care, the proportion that low-income families are paying, because the averages that we're giving are for median income families. So if we look at lower income families, they can pay up to 30%. And what this means in terms of economic stability and equality and mobility is really very significant and needs our attention. So I'll stop there. I look forward to having a conversation about the work of the Women's Bureau, answering questions that folks have, and being in conversation with the other speakers today.
Thank you. We're still having some problems with Professor Kramer. So Jesse, I'm going to go to you to talk a little bit about your work.
Sure. First of all, thank you so much for having this conversation today and for including me in it. I'm really thrilled to be here with some of the most important state and national leaders on this issue. I see legislators here, Rep. Jamie Belcito, McPat for Mom. So I'm really thrilled to be in your company. As the DA said, I'm the founder and executive director of the Mass PPD Fund. We're a nonprofit working on this issue focused on Massachusetts, but I'll just back up and answer the question about how I came to this work, because it does overlap with some of the history of this work here in Massachusetts. So as the DA mentioned, I was the first director of the state commission, now named after Representative Ellen Story back in 2010. And the history there is that after New Jersey started screening all moms, Rep. Story wanted Massachusetts to take a step forward on this and pull together a whole bunch of important leaders on the issue, and drafted this incredibly ambitious bill that required OB screen, required doctor screen, required that it would be paid for by insurers. And that went nowhere fast. It was just too ambitious at the time. But the legislation that did pass as a result of that effort did establish the State Commission on Postpartum Depression, as well as called on the Department of Public Health to promote best practices and to do some important work around screening and data collection. So I would say that the commission has done a ton of important work since then. And like Dr. Mattel, I do sit on that body, most notably supporting the PAP for Moms, which has just been this incredible game changer on our issue. The commission also was responsible for several pilot programs in community health centers in Massachusetts. And as has been mentioned, this is an issue where screening is incredibly important, and those programs focus on screening. The commission also was responsible for pushing Mass Health to cover screening in the pediatric setting up until 6 months. And now I'm happy to be partnering with them on some more advocacy efforts, including the Moms Matter Act, which was championed by Rep. Belcito last session, is now being taken on by a number of legislators, including Senator Miranda and Rep. Fluker Oakley. So in terms of our nonprofit, I had been working as the director of the commission. I also have a background in nonprofit fundraising, and there came a moment where I felt like I was able to put those two pieces together and really fill a gap. You know, if you've it sounds like this is a group that has worked on so many issues. If you work at the State House, you really see the presence of kind of every issue that could impact people's lives. And I think I was just really stunned. This is the #1 complication of pregnancy, and yet, you know, didn't have a large presence in the public conversation at the State House in terms of things folks were advocating for. A lot of the work was being done on a volunteer basis, and just tremendous work, but you know, I think limited without some investment in it. So founded this organization. We have done a number of projects, and I think as we've grown over the past couple of years, we've really found our niche in terms of capacity building. In other words, we're not providing direct service, but there's so many wonderful providers out there that do have good relationships with parents and moms, but they may not know about the resources that are out there, but they may not know how to screen, what to do. So we try to kind of make those links, and particularly in the areas of raising awareness, training, and advocacy, and we work in all of those areas to try to serve folks in the communities with the greatest need.
Thank you. Dr. Mattel, turning to you for a minute, can you tell us a little bit about, just so we all start with the same base of knowledge, like what are some of the risk factors for postpartum depression? How do you tell that from, you know, somebody who's just had a baby, who's maybe having lots of things going on, but we aren't really at that point? And then what are the symptoms that people should be looking for?
So it's a really important question, or a set of questions, really. Postpartum depression is, by its definition, a major depressive disorder that occurs in the perinatal period. The criteria are that the symptoms have to have their onset during pregnancy or in the postpartum period. There are some variable criteria in terms of like the exact timing of how postpartum gets defined, but what we see most often are individuals who have low mood or sad mood. This has to last at least 2 weeks to meet full criteria for major depression, but that doesn't necessarily mean that symptoms even less than that aren't concerning. What we worry about is that the low mood is also accompanied by feelings of hopelessness or helplessness, low self-appraisal, guilt, inability to kind of do the tasks that previously found enjoyable or that are part of one's responsibilities. And then in much more severe cases can be accompanied by thoughts of self-harm or life not being worth living. Depression in and of itself can be part of different types of mood disorders. So depression can be a feature of a bipolar disorder, but it can also most often be part of a major depressive disorder where there is just sort of one mood state that is down, and then otherwise will return to their usual mood state. Bipolar, on the other hand, would be somebody who has the risk of becoming depressed, but also having another mood state, which could be what we call manic or elevated or mixed. And so when we talk about postpartum depression, what we most often see is that individuals will have symptoms that last more than 2 weeks. They often occur they may begin in the early part of the postpartum period immediately after birth or during pregnancy, but don't abate on their own and continue to get worse. We see sometimes that it's not just melancholic depression, but it can be accompanied by anxiety or lots of thoughts, lots of worry, sometimes feeling very anxious and activated, even though quite down. So these are sort of the key features of depression. The risk factors include having had an episode of depression at some point in life before, also having a history of trauma or a history of other sort of challenging early life circumstances, having faced adversity in early life, having a history of mood changes in the context of hormonal fluctuations. So whether that's part of the menstrual cycle or part of taking hormones for contraception or fertility treatment, having a family history of perinatal mood or anxiety disorder. All of these things are really important common risk factors for postpartum or perinatal depression. And I'll just make that distinction that we often talk about depression in the postpartum period, but what we're really seeing is that this is part of a spectrum that can occur during pregnancy or after. And so I'll use the term perinatal kind of as we go forward. But really, this is part of a sort of set of conditions.
And Dr. Biden, you talked about the doctors not knowing what to do about all of that. And you've been running sort of training programs and doing a lot of work around that. Have you seen the interest increase? Have you, and also, what about partners? Like, what kind of training, if any, is anybody giving to partners to, if you're depressed yourself, you might not be recognizing that. How are we teaching people in mothers' lives to have an eye on what's going on?
Yeah, thank you for those questions. They're great questions. So I think in regards to the increase, we have absolutely, fortunately, I'm pleased to say that we have seen an increase in increased interest. So even when we very first started MCPAP for Moms, which, as I mentioned, is a statewide program that aims to build the capacity of the medical community in Massachusetts to respond to mental health concerns. When we first started it, there was not, the guidelines around this there was either a dearth of them or they weren't particularly consistent. And there was really a lot of question with, would the medical professional community, particularly would obstetric providers, really take this on? Would they screen? Would they treat? Would they be talking about this? Was that really appropriate for their role? And at the time, there was not a lot of recommendations around this. That was in 2013 when we started developing MCPAP for Moms that launched in 2014. And so that was almost 10 years ago now. And since then, we have seen the medical community has really developed a huge interest in this, particularly the American College of OBGYN, which the acronym we use is ACOG. ACOG now has screening guidelines around this that are very clear. They used to recommend screening once in pregnancy or postpartum. They're currently recommending their practice guidelines around this, and they will be recommending to screen more often. They just released a safety bundle, which is essentially creates the standard of care, and they recommend screening twice in pregnancy and once postpartum. They also recommend screening for bipolar disorder and also anxiety. More recently, anxiety has been added as a recommended screen. So the standard of care for the professionals working with pregnant and postpartum individuals has changed dramatically in the past 10 years. The expectation now is that the professionals that are working in medical settings with pregnant and postpartum individuals are screening, assessing, and addressing them. Different in obstetric settings, the expectation is they're providing treatment when that's indicated, medication treatment or referring for treatment if it's more complicated. In pediatric settings, the expectation is that they are screening and then discussing and then referring as needed. So I would say there absolutely has been an increased interest. And also, we started our program in Massachusetts. There's now I want to thank a lot of people on this call, particularly Jamie Rep. Balsito, who is very involved in this. There's actually now federal funding. There's now 21 access programs that are modeled off our program here in Massachusetts. We should be very proud in Massachusetts of that. We have the first one. There's now 21 across the country, and that's amazing. It's federally funded. It was written into legislation due to many of the people on this call that I want to, thank for that. And so there's been, federal dollars put towards this. The guidelines are changing. So there's absolutely been increased interest. And that's wonderful, and that's great progress. In regards to partners, your question around partners, I think most of the work that's been done has really been focused on the gestating, like the perinatal individual, who's pregnant or postpartum, who may or may not identify, who many identify as female, but many may not identify as a female. So I'd say that most of the work has been focused on that. There has been work done around supporting the partners who can develop depression themselves. We can have paternal depression, paternal postpartum depression, that can occur. So there has been some work around that. I would say that there's been, overall, we need more progress around supporting the other family members and also educating the other family members. Really, most of its focus, and it's challenging because when the perinatal individual seen in an OB setting, the partner may be there, but not always. And so I think that's an area that we really need to develop much more. And I think that when we think about how to address this, there's a medical setting, which is a lot of what our work is focused on, but we also have to think about these community-based interventions and all the natural support that perinatal individuals have and really harnessing those opportunities. And there's, I think, a lot of opportunities to be doing more in those settings. We heard about, doula care and other community-based interventions that I think we have increasing attention to and evidence for that also really need to be implemented in tandem with these interventions in the medical setting. And they have to focus on not just the perinatal individual, but the whole family.
Thank you. Jesse, you did an interview recently on GBH, and you talked about what is often the case with mental health treatment. People feel stigmatized often around asking for help. Then you've got somebody who's trying to adjust to having a baby. And then we also expect them to kind of be figuring out that they need help and reaching out for help. Like, what can we do to make that, as Dr. Baez said, more of a community issue? Like, and not just the OBGYN. One of the places it occurs to me that you're going all the time with your new baby is to the pediatrician. And are we getting this information to people, for instance, before they have the baby, when they actually might be able to listen and read rather than in those weeks when they've got a new baby?
Yeah, that's a great question. And I really like the multidisciplinary focus. As folks have said, there are just so many interactions with the healthcare system. So this is a situation where the non-specializing provider needs to play a critical role. And then those of us who care about this issue need to support them in playing that role. And MCPAP for Moms has just been, as I said, such a game changer. When we first started working on this issue, we were asking docs to take on this role, but without that backup. And I think that makes a huge difference. I'll say a couple things. I think there's still a ton of room for education, and that is one of the focuses of our organization. And we're trying to think creatively about how we can build on that work this year. So comments have gotten me thinking about focusing on the partner. I would just also kind of touch on the when and the how of screening, because this can be so hidden. You really need to screen over and over. And Representative Balsito's organization, the MMHLA and the March of Dimes have come out with some terrific recommendations around how to screen repeatedly and how the different screens kind of play a different role around. First, you're broaching the issue, and then you're kind of getting the patient used to talking about it, and then on down the line, and then touching on some of those critical points in the first year that can be riskier for parents. I would also say engagement is so important, and really listening. We work a lot with survivors, and I hear a lot of survivors say things like, I wish my doctor had asked me as if he really wanted to know the answer. Or, I wish she had mentioned it as if it was something that could actually happen to me. So I think that that lack of confidence and hesitation, the patient can feel that, and then that screen is not going to be effective. I think also, as you said, community-based organizations, we're helping push this Moms Matter Act that would invest in those programs. I think some of the best efforts have been when health centers partner with community-based organizations. Dr. Mattel and I have worked with a doctor, for example, at South Cove Community Health Center that is in Boston and Chinatown, and they've just done a terrific job both sort of integrating screening, adding a support group, partnering with another community-based organization that can add social support. There are other good examples. In your county, First Connections, for example, partnering with Emerson Hospital. So there are partnerships that can be developed that kind of help on both ends. Like the providers need the docs to kind of help get that person to care, and the doctors need to know that that support is on the other end so they can feel comfortable playing their role of screening. And there are a lot of creative ways to do that that have been really successful.
Thank you. Jill, we know the research shows that having stress in your life during pregnancy is one of the risk factors. And can you talk to us a little bit about the work that you're doing that you think needs to be done about both, maybe I'm pregnant and I'm experiencing some of these mental health challenges. What's my ability to have my employer take that into consideration? Or I'm thinking about what's the cost of childcare going to be like, maybe it's a fifth of our family's budget when I go back to work. Like what can we do? What are you doing, your organization doing about addressing some of those stresses that are so real for people?
All right, thank you for the question. So I really appreciate what Jesse and others who have spoken pointed to in terms of a multidiscipline approach, right? And I think that we do the same thing at the Women's Bureau, where we're thinking about how can we work with partners across the agencies, both within DOL and across government, and then how do we work with partners in the region on the ground, for example. So, to begin with an answer to your question, I'll point back to the White House's blueprint for maternal health crisis. They have a number of actions and proposed solutions that are included in the document. And again, I encourage you to take a look at it. One of them is expanding the National Maternal Health Hotline for pregnant individuals and new mothers, which I think certainly has value. Another one, again, many folks have spoken to this before, how do we expand capacity to screen, assess, treat, and refer for maternal depression? And then the one that I'm particularly interested in terms of the work that we're doing at the Women's Bureau, integrate behavioral health supports in community settings. So what does that look like in terms of medical homes, school-based, other community health centers, community-based organizations, local community, social supports? We're beginning the conversation with our doula partners with an intent of seeking to understand what is the workforce need in order to be robust and resilient, again, to be able to be available and accessible to provide essential services to mothers and families that are welcoming new children. We expect that the conversation will go beyond to, where is there opportunities to provide education and then importantly link families to needed resources. You asked about the costs related to childcare. It's just absolutely untenable in this moment. And I think one of the things that we need to recognize, and again, with deep respect to many of the partners who have joined us here today, Massachusetts is leading the nation in terms of conversations around how do we get there? How do we truly provide access to affordable quality childcare in our communities? But at this point, we have to recognize that it's a failed market, as the U.S. Treasury has explained it. We are currently pushing the costs of childcare on overburdened families and wildly underpaid care providers. And I think that is something we need to, and again, many folks, again, who joined us here today recognize that we are, COVID one of the unintended gifts of, I think, of the pandemic was that we always knew that, childcare was unaffordable, but we really all painfully felt like, what does that mean in terms of the impact on families, the impact on working mothers, and the impact on our economy? And it needs to be addressed, and it needs to be addressed in an equitable way.
And going back to kind of the partners that we have here today from healthcare, Dr. Baya, to you, over time, what have you seen as the interventions or the treatment options that really work best, that are most effective? And how can our partners who joined us here today be thinking about putting those in place?
Thank you for that question. It's a great question. So I think one of the challenges with all mental health, actually, but particularly during the perinatal time period, is the issue isn't about whether we have evidence-based treatments. We have effective and evidence-based treatments that work. We have pharmacotherapy, we have effective pharmacotherapy, we have effective psychotherapy, cognitive behavioral therapy, interpersonal therapy, and there's also psychosocial interventions which have an increased evidence base, including peer support. The challenge is, so these are effective evidence-based treatment options that we have available. The challenge is that people often aren't able to access them. So I'll give a couple of examples of this. So in Massachusetts, if somebody has public health insurance and they need to see a psychiatrist, sometimes they often have to have, the clinic may require that they have 3 therapy appointments before they can even get referred. And often we see that there's a long wait list for a therapist. So we can so one of the challenges is, how do we increase access to these evidence-based treatments and then also help people implement them? So one way to do that is by helping medical settings implement them. So for example, what we've done with building the capacity of the healthcare system. There's also, as you heard about from Jill, the community-based setting. So for example, if we have peer support, to what extent can we leverage these community-based settings so they can implement some of these evidence-based treatments as part of what they're already doing? Then we have short-term therapy. So rather than I think the concept of everybody seeing a psychotherapist for one-to-one long-term therapy is lovely. I think we all deserve that and should get that. However, that is not really feasible. So to what extent can we train people that are working in the community settings, already acting with individuals, to have this be integrated into what they're doing? And peer support is an example of that. So I think that's where we need to be focusing on, is thinking about, how do we increase access to the evidence-based treatments, and what are the settings in which people are already being seen where we can implement that as part of the existing workflow? So I think that's where we have a lot of opportunities. And I want to add something that, I recently read the book by Tom Ilsell. He talks about the parallel between, because Jill, you've been talking a lot about the White House Blueprint on maternal mental health. And the White House Blueprint calls for a data harmonization approach throughout the country. And when we think about, Tom Insall in his book talks about acute lymphoblastic leukemia, which is a childhood cancer. In the 70s, it had a 90% death rate. We had evidence-based treatments that were working. Chemotherapy worked, treatments worked, but people would go into remission and then they died because it wouldn't keep going. So they developed a network of all these programs throughout the country, a cancer network for kids, and they studied this and they implemented it such that now there's a 90% survival rate from childhood cancer, specifically for ALL. We need to do the same for mental health. So we have these evidence-based treatments, but people either aren't getting them, they're getting them too late, or they get them, but they don't necessarily continue them because of ongoing access issues. And that is all based on, a lot of times, socioeconomic situation and many, many other forces that are driving these sort of political, social determinants of health that make it really hard for particularly for certain groups, to access treatment. So when we think about mental health as a parallel, I think that we, thinking about it in that way, so there's an opportunity to take the evidence-based interventions that we have and really look at the systems in which they're being provided and change them so that people access them and they get better and then they stay better. But we really have to look at the whole systems in order to do that. And hopefully we can have the remission rates change just like they did for childhood cancer, decades ago.
Thank you. Thank you. I want to acknowledge as well Representative Sally Kearns, who's joined us. I didn't see her earlier, so thank you for being with us. I want to encourage people to put their questions in the chat, but before I do that, Dr. Patel, if I could, the numbers that I talked about earlier for women of color and the rates at which they suffer really severe or fatal pregnancy complications are terrible. And I just wanted to give you an opportunity to talk a little bit about your work on the Commission on Racial Inequities in Maternal Health. Like, what are some of the key findings and the recommendations that have come from that work, while people are putting questions in the chat?
Absolutely. And thank you for highlighting the commission. So the Racial Equity or Inequity in Maternal Health Commission was sort of brought together to really address maternal health broadly. And mental health was a piece of what was addressed, but really only a small piece. And I think it speaks to the need to integrate kind of the whole person. So an individual is not just their bodily health or their mental health, but it's the community they're in, it's the context they're in. And a lot of what the report from the commission highlighted was that all of the things that have already been discussed by my esteemed panelists have inequitably and disproportionately impact communities of color or individuals of color. And so the workforce challenges, for example, that we're describing or that Nancy sort of spoke about, that there are not enough direct mental health care providers to meet all of the needs. This is particularly notable in the context of there being inadequate cultural concordance and responsivity in the workforce. And so really a call to develop the workforce of mental health providers that can meet individuals and have some shared identities and ways in which that individuals of color may also like to meet with providers of color, where providers of color may have particular understanding or sense of shared identity, shared experience that can facilitate the work. But the barriers there are many, including relatively poor reimbursement, the challenges of higher education and the systemic barriers that prevent. So the commission drew attention to that. The other thing that the report draws attention to is the need for significant amount of training in the healthcare system. Our healthcare system, while many, many amazing aspects of care can happen, there's also a very much baked in institutional and systemic set of challenges, racism and challenges around social determinants of health and medical trauma that we as providers have to sort of take some ownership of and learning around. And so the commission called for training throughout the healthcare system for all disciplines of providers around implicit bias, around medical racism, around trauma-informed care. The other thing that the commission noted was the increased need for paid family medical leave. This is a concept that, again, has been raised here, but in particular disproportionately impacts communities of color and individuals of color. And another thing, I think the one other sort of main component of the report was really to think about enhancing the composition and the funding for the maternal mortality review process in our state, to really think about engaging individuals with lived experience, individuals with family members of people who have experienced maternal health challenges, whether they be physical or mental health, and engaging more funding for people, not asking people to do this work as volunteers. So those were some of the high points of that commission. And then also so much more. There was a lot of work that went into sort of hearing stories and hearing sort of like deep sets of experiences that informed it.
Thank you. Thank you. Questions for our panelists that people want to either raise their hand or put in the chat or? And maybe while people are collecting that, and if we could expand for a minute, I see that former Representative Belzito's here, Jamie Belzito. I'd love to give you an opportunity to have a minute to talk about policy actions on the national level and some of the work that you've been doing. Nothing like calling you out in the car, but.
Well, DA Ryan, I want to say thank you so much for you pulling this together. It just speaks volumes of your character, and I'm very grateful for this opportunity. Yes, I am in the parking lot. My job now is to make sure that my kids are fed at all points of the day, and Market Basket is my destination. But this is very, this really was, I'm taking a look at who's here today. Dr. Mittal, Dr. Byatt, Jesse, you know, a little bit of like the band is back together here on something we've been working on since 2015, which is when I really came out with my own lived experience. So this is very personal to me. And I took my background in policy and my lived experience and found a specific niche at the national level. And subsequently, we've been able to push national policy by way of what we've done in Massachusetts. And I want to speed up to say now it's 2023, and a lot of our policy initiatives with taking the telephone psychiatry access program and project to other states has yielded conclusive evidence-based data points to say that we are actually helping lives. And from there, with the Maternal Mental Health Leadership Alliance that I founded, we've worked with Congress to put in another $10+ million into evangelizing new programs that are culturally competent, targeted towards state level programs to help women with the #1 complication of all pregnancy, mental health challenges, which are temporary, treatable, and potentially preventable. And we also were able to get, for the first time ever, a 24-hour-a-day, 7-day-a-week hotline, of which I dropped that information into the chat line. It is connected with 988. I do want to make a point with that. And I wanted to bring something up in regards to the fact that when it comes to our federal and then our state, we have a number of bills that have been sitting in the House and sitting in the Senate that have been geared towards screening mental health complications in the pediatrician's office, dedicating a specific workforce that's culturally competent, diverse, and speaking directly to perinatal psychiatry needs, not generalized mental health, which we are also suffering a shortage from, but really being specific around a very unique space, and that's perinatal mental health support. We just talked about peer support. I know when I found fellow parents that were dealing with what I thought was my own individualized issue, it really helped. And to see that folks got to the other side, full coverage of Medicaid. We do a pretty good job on that here in the state, but there are still those that are left out. I love the conversation around paid family leave. That's not universal, and it is a subset of folks that have that opportunity. And then there was a bill put on the floor. When do we take a look at giving individuals support from a mental health standpoint and getting them that support that they need versus incarceration when it comes to very extreme cases? And these are a handful of bills and many more. So I thank you for the opportunity, and I'm here to partner, and I see a lot of empathy and want to understand something that is so common. And I thank you again for the opportunity to speak into this amazing group.
Thank you. Thank you. And Jesse, if I could, I wanted to just ask you for a moment if you'd talk a little bit about the Moms Matter Act that Senator Miranda and Representative Fluker Oakley worked on, what that does in terms of the investment on community-based organizations and addressing some of the racial disparities.
Sure. So Rep. Balsito, who's here, and Senator Lovely filed this bill last year. And in the meantime, there has been a national policy effort around this issue called Mind the Gap that other leaders here have been involved in. Our state had the opportunity to run with some piece of that. We have been hearing over and over about the workforce issue, about the lack of culturally congruent care. So this coalition here in Massachusetts, I just put the link in around our effort, is running with the work that Rep. Balsito started, that Rep. Fluker Oakley and Senator Miranda are championing, among other Rep. Karen's this session. And the bill is modeled after the federal Moms Matter Act. So it's 2 grant programs. One would invest in expanding and diversifying the perinatal mental health workforce, if folks have said, specializing in this issue, focusing on diversity in those providers, culturally congruent care. So that's the first grant. And the second grant would invest in community-based organizations that do any number of what we know are effective programs, from group prenatal care, doula care, suicide prevention, STD care. It's really a terrific list of programs that would invest in there. So we'd love all of your support for that. I think there are many other policy changes that need to be made around screening, around sentencing, home visiting. You know, what can we do to support parents? You know, I love that the conversation, and we're talking about family leave, we're talking about childcare. You know, it is a mental illness, but it doesn't come out of nowhere. The context for folks is really just, you know, expecting mothers and other parents to kind of go it alone without practical and emotional support. So I think there, not only can we work on this Moms Matter Act, but we can come together around a whole host of other policies to make things better here in Massachusetts.
And somehow we lost Professor Kramer, but one of the things she would have talked about, has been part of his recent conversations, is it has for many years been the law in a number of European countries, and it is also the law, has been the law since 1948 in Canada, that women who are accused of causing the death of their own children within 12 months of their birth, there is a separate statute that they charge. It's what we would consider a relatively low-level felony, carrying a maximum sentence of 5 years, rather than being in the position where we are in this country with the only charge is usually a murder charge. So that just reflects a whole different approach. We also have here in Massachusetts now a responsibility to consider in sentencing when somebody is a primary caretaker. And that is something that we train our DAs around. There's probably could be more education, particularly for judges, around that fact, that when somebody appears before the court and they're the primary caretaker of children, that is supposed to be a factor, just like we consider people's jobs or their records or lots of other things. We should be considering what the impact could be on those children if that parent is removed from the equation. So I think there's changes. I think you're right. It is something that is different and something that could certainly use work on that level as well. Anything else? Anything that our panelists want to add? Other questions that people have on this topic? No? I want to thank all of you for being with us today. I think this is a conversation that, although it was triggered by tragedy, is probably long overdue. And certainly one that many, many people, when they hear the conversation related to their own experience and maybe didn't realize that they were part of this conversation, these issues, thought it was their own personal, at some level, their own failure to be a good mom or to appropriately welcome their baby. And that some of these things, like the child care, that, you know, trying to figure that out, or trying to navigate work, or how do you go back to work and how do you make that affordable for your family? Those should be much more community issues than they are. So I am grateful, so very grateful to all of our panelists today for helping us to think about these issues. This is not going to be the last time we address these issues. And thank you all for making time in your day to join us as well. So thank you very much. Thank you.